Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 509 of our pharmacotherapy series, which majors in chronic kidney disease. This case applies to patient GBS in part 508 of this pharmacotherapy series. My first question to you reads: how should GBS's kidney disease be managed? Regarding management, because reversal of GBS's kidney disease is not possible, the primary goals are to delay the need for dialysis therapy as long as possible and to manage complications. The three main risk factors for the progression of incipient nephropathy to clinical diabetic nephropathy are poor glycemic control, systemic hypertension, and high dietary protein intake, that is less than 1.3 grams per kilogram per day. GBS's current random blood glucose concentration of 289 milligrams per deciliter, history of elevated glucose on prior visits, and elevated hemoglobin A1c indicate poorly controlled diabetes mellitus, which will accelerate the progression of diabetic nephropathy and time to ESRD. Thus, her blood glucose concentrations should be maintained within target goals while avoiding hypoglycemia. GBS's elevated blood pressure is likely the result of kidney disease and changes in intravascular volume. Reduction in blood pressure may prevent further damage to functioning nephrons and slow the progression to ESRD. Similarly, reductions in dietary protein intake of approximately 0.8 gram per kilogram body weight per day, should be initiated in an attempt to reduce the rate of further progression, although this needs to be evaluated in the context of her overall nutritional status. We will now briefly consider intensive glucose control. Strict glycemic control can improve diabetic management, reduce proteinuria, and slow the rate of decline in eGFR. The Diabetes Control and Complications Trial, abbreviated as DCCT, a randomized clinical trial of type 1 diabetic patients, N equals 1,441, demonstrated that maintaining fasting blood glucose concentrations between 70 and 120 milligrams per deciliter, with postprandial blood glucose concentrations less than 180 milligrams per deciliter, delayed the onset and progression of microvascular diseases such as diabetic nephropathy and reduced the risk of CKD. Patients were randomly assigned to receive either conventional insulin treatment, 1 to 2 insulin doses a day, or intensive treatment, 3 or more insulin doses a day. After a mean follow-up of 6.5 years, The intensive insulin regimen reduced the overall risk of moderately increased albuminuria by 39% and severely increased albuminuria by 54%. Unfortunately, stricter glycemic control was associated with an increased incidence of hypoglycemic episodes. The UK Prospective Diabetes Study, UKPDS, demonstrated the beneficial effects of intensive glycemic control in patients with type 2 diabetes mellitus, N equals 3,867. During a 10-year treatment period, intensive glucose control, fasting glucose less than 108 mg per deciliter, with either insulin or an oral sulfonylurea reduced microvascular complications, e.g., retinopathy and nephropathy, including albuminuria by 33%, when compared with conventional dietary therapy, fasting glucose less than 270 mg per deciliter. Similar to the DCCT, intensive treatment groups in the UKPDS experienced more hypoglycemic reactions. Additionally, diabetes trials such as Action to Control Cardiovascular Risk in Diabetes, abbreviated as ACCORD, and Action in Diabetes and Vascular Disease, PROTERAX, and Diamacron MR Controlled Evaluation, abbreviated as ADVANCE, evaluated the macrovascular and microvascular outcomes associated with intensive glucose control in type 2 diabetics. The ACCORD trial showed a 21% reduction in the development of moderately increased albuminuria cases and a 32% reduction in severely increased albuminuria cases. In the ADVANCE trial, there was a 9% reduction in moderately increased albuminuria and 30% reduction in progression to severely increased albuminuria. Similar to other studies, severe hypoglycemia, although uncommon, was more common in the intensive control group. KDIGO guidelines for evaluation and management of CKD recommend a hemoglobin A1C of approximately 7% to prevent or delay progression of the microvascular complications of diabetes, including diabetic kidney disease. Targeting an A1C less than 7% increases patients' risk of experiencing hypoglycemia and without improvements in cardiovascular outcomes and should be avoided. In CKD, patients with diabetes and comorbidities are a limited life expectancy and risk of hypoglycemia. A target A1C above 7% is suggested. GBS will benefit from a multifactorial approach addressing glycemic control and hypertension to slow her progression of CKD from diabetes mellitus. Appropriately dosed oral and/or insulin therapy can achieve these goals despite her advanced kidney disease. GBS should be counseled on appropriate techniques for home glucose monitoring, particularly given her history of non-compliance. Compliance with this regimen will require motivation as well as encouragement from GBS's family and healthcare providers. We will now look at antihypertensive therapy. Systemic hypertension usually occurs with the development of normal to moderately increased albuminuria in patients with type 1 diabetes mellitus. It is also present in about 1/3 of patients at the time of diagnosis of type 2 diabetes mellitus, and hastens the progression of kidney disease in both groups. The coexistence of these disorders further increases the risk of cardiovascular events. Hypertension may be a result of underlying diabetic nephropathy and increased plasma volume or increased peripheral vascular resistance. Regardless of the etiology, virtually any level of untreated hypertension, either systemic or intraglomerular, is associated with a reduction in eGFR. As such, The control of systemic and intraglomerular blood pressure is perhaps the single most important factor for retarding the progression of kidney disease and has been shown to increase life expectancy in patients with type 1 diabetes mellitus. Patients with diabetes mellitus and hypertension exhibit elevated systemic vascular resistance and increased vasoconstriction from angiotensin II, which are in large part responsible for the glomerular damage characteristic of diabetic nephropathy. Although the management of hypertension with virtually any agent can attenuate the progression of kidney disease, angiotensin-converting enzyme inhibitors, which inhibit the synthesis of angiotensin II, and angiotensin II receptor blocker, which block angiotensin II at 1 receptors, are preferred owing, in part, to the effects of these agents on renal hemodynamics. KDIGO guidelines recommend angiotensin-converting enzyme inhibitor or angiotensin II receptor blocker for the treatment of hypertension in all CKD patients with albumin excretion rate greater than 300 mg per 24-hour and diabetic CKD adults with albumin excretion rate equal to or greater than 30 mg per 24-hour. JNC8 recommends angiotensin-converting enzyme inhibitor or angiotensin II receptor blocker for all CKD patients regardless of race and with an albumin to creatinine ratio greater than 30 mg per gram to improve kidney outcomes. Reductions in proteinuria and a decreased rate of decline in eGFR have been observed with angiotensin-converting enzyme inhibitors and angiotensin II receptor blocker in patients with type 1 and type 2 diabetes. As a result of these and other studies, angiotensin-converting enzyme inhibitors or angiotensin II receptor blocker should be considered for all patients with diabetes and albumin excretion rate greater than 30 mg over 24-hour, even if their blood pressure is normal. Angiotensin-converting enzyme inhibitor and angiotensin II receptor blockers have similar efficacy in blood pressure reduction when dosed accordingly. Combination therapy is associated with an increased risk of dialysis and doubling of serum creatinine and should be avoided. Additionally, spironolactone in combination with an angiotensin-converting enzyme inhibitor or angiotensin II receptor blocker lowers albuminuria independent of blood pressure control in patients with type 2 diabetes mellitus. However, the risk of hyperkalemia increases significantly, limiting the benefit of this therapy. Aliskiren, an oral direct renin inhibitor, has demonstrated a reduction in albuminuria when added to losartan. However, additional studies have resulted in early termination because of increased risk of adverse events and lack of demonstrable benefits. The role of aliskiren is uncertain and benefits do not appear to compare with angiotensin-converting enzyme inhibitor and angiotensin II receptor blockers. The primary goal in patient GBS is to delay development of ESRD and to reduce the risk of cardiovascular complications and death. Treatment with an angiotensin-converting enzyme inhibitor, e.g., ramipril, should be initiated, because she has substantial albuminuria, that is 700 mg per day, and an elevated blood pressure. An angiotensin II receptor blocker, e.g., losartan, is a reasonable alternative to an angiotensin-converting enzyme inhibitor in patients with angiotensin-converting enzyme inhibitor-induced cough or other adverse effects that do not cross-react with an angiotensin II receptor blocker. The initial product selected is generally based on tolerance to therapy and cost. A goal blood pressure for patient GBS, given the fact that she has diabetes and kidney disease, is a blood pressure less than 130 systolic 80 diastolic, 140 systolic 90 diastolic may be reasonable goal as well. Because the beneficial effects of angiotensin-converting enzyme inhibitor therapy occur over the course of months to years, patient GBS must be monitored on a long-term basis for changes in kidney function and albuminuria and for side effects of therapy, such as hyperkalemia. A moderate increase in serum creatinine is acceptable with initiation of therapy with angiotensin-converting enzyme inhibitors or angiotensin II receptor blockers. Contraindications for the use of angiotensin-converting enzyme inhibitors and angiotensin II receptor blockers include bilateral kidney artery stenosis and pregnancy. The risk of hyperkalemia must also be weighed against the potential beneficial effects of these agents. Some evidence suggests that a non-dihydropyridine calcium channel blocker, e.g., diltiazem, and verapamil, may be beneficial alone or in combination with an angiotensin-converting enzyme inhibitor. Diuretics may be considered for patients with diabetic nephropathy and edema, depending on the degree of kidney function. For patients with kidney disease as extensive as that observed in patient GBS, e.g. FR less than 30 ml per minute per 1.73 meters squared, loop diuretics are generally preferred because, unlike thiazide diuretics, they may retain their effect at this reduced eGFR level. Other antihypertensive agents may be considered based on response to initial therapy and changes in kidney function. Currently, clinical studies are examining the use of an aldosterone blocker, spironolactone, and a selective aldosterone blocker, that is eplerenone, for use in patients with diabetic nephropathy and overt proteinuria on maximal doses of both an angiotensin-converting enzyme inhibitor and an angiotensin II receptor blocker. The antiproteinuric effect of these agents has been confirmed by several studies, but the potential increased risk for hyperkalemia when adding these agents to patients already taking an angiotensin-converting enzyme inhibitor and angiotensin II receptor blocker warrants further evaluation of their use. The effect on slowing progression of kidney disease has not been evaluated with these agents. Additionally, patient GBS should be counseled regarding an exercise program compatible with her cardiovascular health and tolerance. We will now briefly look at dietary protein restriction. High protein consumption accelerates the progression of diabetic nephropathy, presumably because of increased glomerular hyperfiltration and intraglomerular pressure. In patients with overt albuminuria, some evidence indicates that the rate of decline in eGFR, as well as urinary albumin excretion, can be blunted by restricting protein intake to 0.8 gram per kilogram per day and maintaining an isocaloric diet. Limited evidence indicates, however, a beneficial role of dietary protein restriction in diabetic patients with microalbuminuria. Nonetheless, given the potential benefits to delay progression of kidney disease, patient GBS should be advised to maintain an isocaloric diet with a protein intake of 0.8 gram per kilogram per day, that is approximately 10% of daily calories. Because the typical Western diet is high in protein, some patients may have difficulty complying with such a low-protein diet because of its perceived unpalatability. Intervention by a dietitian is recommended to design a feasible dietary regimen limited in protein, yet consistent with nutritional requirements in a diabetic patient. This case refers to patient GBS from the previous part of this series on CKD. Assess GBS's sodium and water balance. So my first question to you reads: what interventions may be used to address this problem? As illustrated in patient GBS, Patients in the latter stages of CKD commonly retain sodium and water. This is supported by GBS's elevated blood pressure, 2+ pedal edema, and mild pulmonary congestion. Sodium and water retention also led to weight gain. Early in the course of CKD, glomerular and tubular adaptive processes develop as an increase in the fractional excretion of sodium, abbreviated as FeNA. These mechanisms enable patients to maintain relatively normal sodium and water homeostasis. As GBS's normal serum sodium concentration indicates, this value is of little use in establishing the diagnosis of total body sodium and fluid excess, because retention of sodium and water usually occurs in an isotonic fashion, leaving the serum sodium concentration relatively normal. Eventually, patients with advanced kidney dysfunction exhibit signs of sodium and fluid retention because sodium balance is maintained at the expense of increased extracellular volume, which results in hypertension. Expansion of blood volume, if not controlled, can cause peripheral edema, heart failure, and pulmonary edema. Thus, management of sodium and water retention is essential. To achieve control, most patients with advanced kidney disease are placed on sodium restriction, that is 2 grams per day, and fluid restriction, to approximately 1 to 2 liters per day. These restrictions will depend on the current dietary intake, extent of volume overload, and urine output, and should be altered according to the special needs of the patient. Because some patients with advanced kidney disease produce normal amounts of urine, whereas others may produce less or no urine for hemodialysis patients, fluid restrictions must be based on urine output. Diuretic therapy, usually with loop diuretics, e.g., furosemide, bumetanide, and torsemide, is often required. Combination therapy with 2 different types of diuretics, i.e., loop and thiazide, may be successful in patients resistant to a single agent. However, limitations in efficacy of diuretics exist under certain conditions, e.g., a reduced eGFR and hypoalbuminemia, and these situations must be considered when designing a diuretic regimen. Thiazide diuretics as single agents are generally not effective when the eGFR is less than 30 ml per minute per 1.73 meters squared, as in GBS. The possible exception is use of the thiazide-like diuretic, metalasen, which may retain its effect at reduced eGFRs. As kidney failure progresses, manifestations of excess fluid accumulation, i.e., edema, uncontrollable hypertension, develop that are resistant to more conventional interventions, and dialysis will be required to control volume status. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 510.